Awesome. Yeah. Excellent. That's great. So today we'll talk about CRRT. I can tell everybody is super excited. I mean, I couldn't sleep. I was so excited. So we'll talk about the concept. We'll talk about the circuit. We'll talk about the anticoagulation, and then we'll also talk about the citrate as well. So most of the slides are from my counterpart and my friend, Dr. Connor. He's also an ICU doc and a nephrologist, just like yours truly. And he's at Emory. But I have modified all the slides so that it's more applicable to us and the machine, which is next stage that we use. So let's keep it interactive. You can stop me at any point and kind of if you have any questions, just throw the questions. Folks who are on WebEx, I think Hannah can monitor the chat, and you can just let me know, and we can kind of answer questions as we go. Okay, so the first question is, why the heck do we need any anticoagulation, right? Why do we need it? Exactly. It's so interesting. There's a concept of like prescribed dose. I can prescribe whatever dose I want, but that ain't going to be the delivered dose, right? So let me ask you this. And we may have discussed this on rounds, but off the prescribed dose, what's the percentage of the dose that's really delivered for CRRT? Any idea? Just throw any. 70%. Close. Very close. It's about 64%. So the nephrologist might think, okay, I dose the patient thinking that the patient will get dialysis for 24 hours. Ain't happening. Does not happen, right? And it's actually interesting that if you do right for a 24-hour therapy, what you get is 16 hours plus minus 3. Okay, so what are the different options? One is, okay, none. Second could be heparin. Third could be regional heparin. So which means, pre-filter you give heparin and post-filter you do protamine, right? Or there could be RCA, which is the citrate anticoagulation. All right, so what's the one electrolyte that is so crucial to form a clot? What do you guys think? What's the one electrolyte that helps you form a clot? Calcium, right? Calcium. I know. No, there's no trick questions here. So it's calcium, right? And that's exactly how the citrate works. It binds to the calcium in the filter. And then, again, this is a regional anticoagulation, which means we are only anticoagulating the filter, not the patient. So that prevents the activation of calcium-dependent clot formation. And citrate and the calcium complexes, they are mostly cleared by CRRT. And as much as 60% of these complexes can be cleared by the filter. So just keep that in mind. Now, it depends on two things. One is the dose. So higher the dose, more the citrate will be cleared. And the second thing would be, if the filter is good, more citrate will be cleared, right? If the filter is starting to get clogged and clotted, then you'll have less of the citrate that's being cleared, right? And we actually use pre-filter replacement fluid. And guess what? We do not have any calcium in the bags, right? So that's why we need calcium supplementation. So the anticoagulant effect is measured by the post-filter ionized calcium, right? And yeah, we do. But for citrate, we use the bags that don't have any calcium. Because let's say if we use bags with calcium, that kind of defeats the purpose. Because we're trying to bind all the calcium, so the filter is kind of, anticoagulated. So when we use citrate, we do not use calcium in the bag. And the anticoagulation is reversed when the blood is returned and mixed with the blood containing pre-ionized calcium. Just like I said, that's why we do the calcium drips, either gluconate or chloride. And citrate plus ionized calcium, this becomes calcium citrate. So this is what you see as the total calcium. This is not the biologically active calcium. This is the total calcium. And the biologically active calcium is the ionized calcium. Okay, now, if anybody has caffeine close to them, this might be a good time. Okay, so let's talk about the circuit. Okay, and Olivia, this will be very relevant to you as well. So the way it works is, let me use the mouse over here. So this is the patient, and this is the arterial line. That is the dirty blood going from the patient into the filter. And over here is the citrate solution. This is a separate IV pump that we use for the citrate solution. And this is your blood flow or the blood pump, right? And again, just like we said, citrate will bind to the ionized calcium, reducing its concentration. Olivia, yeah. Yeah, so that's a great question. So in center, we just have a filter, right? Everything else, the modules are all within the machine, right? So all you do is the filter, and then you have a bicarb bath, right? But with CRRT, it's actually the ICU nurses who put the filter together. Yeah. So over here, as you see, this is the filter. And when we are giving citrate at the dose that we use here, it's usually about a 3 millimoles per liter citrate level that is achieved within the filter. And that is good enough to give you ionized calcium less than 0.3, okay? And this will become relevant in a second. And then we talked about this, up to 60% of this calcium and citrate complexes can be cleared just by the filter, okay? And then this is your effluent. Now, we don't do post-filter fluids, so let's not worry about this. In the next slide, you'll see the pre-filter part of the next stage. And again, before the blood goes to the patient, so this is your venous line, we infuse calcium. Why is that? Because we don't want to anticoagulate the patient, right? We don't want systemic anticoagulation that you're so used to see in the cardiology world, Olivia, right? We don't want to systemically anticoagulate the patient. Okay. Okay, so there we go. So the normal blood level of citrate is next to nothing. Okay, it's 0.05 millimoles per liter. The citrate level of 4 to 6 will give you that ionized calcium less than 0.3. And that's what we do, right? And just so you know, the blood products, they actually have citrate in them as a stabilizer, right? So they actually have 12 to 15 millimoles per liter. So when you are transfusing blood products, just keep in mind that you are giving 3 to 4 times the dose of citrate that you are giving to the pump. So just keep that in mind. Okay, so let's talk about next stage, okay? So this is what we do. So this is the patient, that's the arterial line. This is your T connector. That's where you will use the IV heparin if you're doing a heparin drip, or the citrate via the pump. And this is the blood pump. And this is where we give the pre-filter replacement fluid, okay, before the blood goes to the filter. And it's very interesting because, I get these questions about the filtration fraction. It's really important, but most of the literature for filtration fraction actually comes from post-filter fluid. And when you're using pre-filter and citrate on top of it, it's not as important, okay? And then this is your effluent. So that's what goes into the toilet, right, for the sink. Now you can infuse anything via the T connector, but the next stage machine, it does not recognize that. So when you're doing your intake and output calculations, make sure you put that in. So let's say if your citrate is running at 300 cc's an hour, you have to put that into your intake, okay? So let's do a trivia. So next stage actually has 3 pumps. You have a blood pump, you have a replacement fluid pump, and then you have an effluent pump. So what's the maximum that you can have, like a blood flow rate? On or off with next stage? On next stage. What's the maximum? Keep going up. It's 600 cc's per minute. So a lot, right? So we always do 200. That's kind of, our default. And what about the replacement fluid? What's the maximum that we can give a replacement fluid rate in liters per hour? Close, go up. I mean, usually we are doing 4 to 5 liters because patients don't need it, right? But on the next stage machine, you can go up as high as 12 liters an hour. And you can pull, any idea on how much you can pull, like the maximum? 2.4 liters an hour. I know, right? So what's going to happen is, so yeah, fluid, the maximum could be 12 liters from the replacement fluid and 2.4 pulling. So it could be 14.4. That's the maximum on the next stage device. Yeah, but we don't do it because A, the patient don't need it, and B, it's pretty expensive. All right. So the extracorporeal clearance of calcium citrate through the filter, it's same as urea. So it's very, very good. And the sieving coefficient is close to 1. So what does that mean? I think this is something that you would have done in your course, the sieving coefficient. So that tells you, like, what's the percentage of a solute, citrate in this case, that gets completely eliminated going through the filter? What's the percentage? And citrate is close to 1. Almost 100% can be cleared by the citrate. So it's really hard to get citrate toxicity. Okay. And this comes every now and then. Why do we do CVH? Why not CVHD? The clearance is exactly the same. And it's very interesting. FDA actually treats dialysate as a device and replacement fluid as a drug. Don't ask me why. But you don't need CVHD to get a good clearance. It's about the same. Dialysate is way more expensive, and you don't need that. Okay. Now the other thing is citric acid. The half-life is like 5 minutes, so it's hard to get citrate toxicity. And we'll talk about it. It can still happen. So the citrate is usually metabolized by the liver, kidneys, and the muscles, but predominantly by the liver. Okay, so if somebody's liver is shot, that would be a patient that you would probably avoid citrate. And severe systemic hypoperfusion, which means shock and acute liver failure, may increase the risk of complication from RCA, which is a regional citrate anticoagulation. And what is the one lab that will give you the biggest bang as far as predicting citrate toxicity? You can look at the slide. Yeah, lactate. So 4 is a good number to remember, okay? And there's one more lab value that's very, very important, and actually pretty much as good as lactate, because lactate is looking at the hypoperfusion. But what is one test that you can do which can tell you about the liver and is equally good in predicting citrate toxicity? Any ideas? Just throw something. LFTs, yeah, but what in the LFTs? What as part of the LFTs? It's actually one of the coagulants that you look for. It's actually the prothrombin time, PT, okay? Because that's looking at the synthetic function of the liver. How healthy is this liver, okay? And I think the value that we go by is 35. So the prothrombin time is about 35. That again tells you the liver is not as healthy, and we have to be careful when we use citrate. Okay, so all the nephrology guidelines are guidelines since 2012. What they're saying is, if somebody has no bleeding risk and on CRRT, use citrate over heparin or over anything else. When I say anything else, that means no anticoagulation. And this is even more interesting. If somebody has an increased bleeding risk, guess what? Use citrate. So they are pretty clear, because the data is pretty clear, that they want, or they suggest using citrate. Now, when the filter goes down, Ellie, how much time does it take for you to put it back together? 30 minutes? Now, 30 minutes? you're on this end of the spectrum where you're very good. On an average, it's 45 minutes or so, right? And that is a uninterrupted 45 minutes. How often does that happen in the ICU? Not very often, right? So that's the whole point. If you use citrate, the half-life of the filter, it's prolonged. And our patients, especially in the ICU, a lot of these patients who have shock, their platelets are low, or anybody who's septic, their platelets can go low, right? And so you can't use heparin in those patients, but citrate, no problems. You can go ahead and use it. And then when you use citrate, the amount of blood products needed, that also goes down as compared to, let's say, heparin. All right, so these are the variety of citrate solutions that are out there. The one that we use is actually over here, ACDA, which is anticoagulant citrate dextrose A. And it's interesting because we do have 225 of sodium in it. It's good to know these things, but sometimes you can see acid-base issues. And then you have trisodium citrate, which is 75 millimoles. And then you have citric acid, which is kind of half the amount of trisodium citrate. And trisodium citrate and citric acid together, this is giving the total citrate buffer load. Okay, so it's a combination of these two things. And the bags, I think it comes in half a liter, liter, and 5 liters as well. We use 5 liters, right? The bags that we use, or is it the 1 liter bag? Okay, okay. So replacement fluid is 5 liters. Yeah. Yeah. I know. Yeah, so your replacement fluid is 5 liters, but your citrate is a liter bag. Okay, another trivia. Ready? Okay, how many bags can you hang on a next stage machine? Good job. 9. Exactly right. Yay. All right. So let's talk about, what's the plus and what's the negatives of RCA. The advantage is, it avoids systemic bleeding complications. So the amount of blood products that you're using is going to be way less. It doubles as buffer because in the replacement fluid, you already have bicarb. And then you're getting citrate, and if the liver is functional, then 1 molecule of citrate will be converted to 3 molecules of bicarb. So that's why you're getting double the buffer, right? 1 from the citrate, 1 from the bicarb in the replacement fluid. And when we have done head-to-head comparisons between heparin and citrate, citrate is much more superior. And again, it does not cause any thrombocytopenia, and of course can be used in thrombocytopenia. The disadvantages are mainly acid-base, and one is metabolic alkalosis, and this happens if there's citrate overdose or toxicity. The second is metabolic acidosis, and this also occurs mainly when you have liver disease or a shock state. Okay. So again, both of them, so citrate toxicity can give either metabolic acidosis or metabolic alkalosis. Just keep that in mind. And then hypernatremia. If we are using sort of hypertonic citrate solutions, we can have hypernatremia. But the one we use, we don't hardly see any hypernatremia. And then, of course, the calcium. I mean, all this is built around calcium, right? So you can have both hypo and hypercalcemias. All right, so again, talking about the acid-base implications. So as we have talked, up to 60% of this calcium and citrate complexes can be cleared by the filter, but the rest still goes back to the patient, right? And usually if the liver is functional, the citric acid half-life, 5 minutes. So within 20 minutes, if you have a functional liver, it's out, right? 20 to 30 minutes, it's out. But again, that's the big caveat. The liver has to be functional because the kidneys and the skeletal muscles, they don't do the majority of the metabolism happens in the liver. Okay, so we talked about hypernatremia. And again, sometimes it's important to see what drips are running on the patients. So if somebody is getting sodium chloride 0.9%, I mean, that's a liter is like 9 grams of sodium. If somebody is getting pushes of bicarb for whatever reason, that is not 0.9%, that's 8.4%. So that's almost like 10 times as potent as, saline bag. Okay. So those things are important, when we are talking about hyponatremia, because the concentration is quite high, especially in the pushes. And then the other thing would be to watch for parenteral nutrition. Because if somebody's on TPN, then we have to make sure, the sodium content there is kind of modulated. So hypercalcemia, again, systemic citrate metabolism decreases, which lowers the ionized calcium. So when we talk about hyper and hypocalcemia, we're not talking about total calcium. We're talking about ionized, which is the biologically active calcium. And in hypocalcemia, you see the ionized calcium go down. And that's where, the calcium ratio comes into play. Because if your ionized calcium, the systemic ionized calcium goes down, then your calcium ratio will go up. Okay, and that's a surrogate marker of, okay, let's look at everything else. Are we reaching a point where our patient might get citrate toxic? Okay. And what do you need to do if somebody gets citrate toxic? What all can you do? One, you can increase the, what is it? Okay, the first thing is you can increase the dialysis dose. Because remember, 60% of that citrate is going through the filter, right? So you can do that. What else can you do? You can decrease the amount of citrate that you're giving to the patient. So what does that mean? So usually the target for post-filter is 0.3 to 0.5, right? And you may have seen me sometimes write 0.3 to 0.7. So I'm kind of, going towards the higher side, which means less citrate. Because more the citrate, less will be your ionized calcium level, right? So you can do that. And of course, if the patient is getting liver failure or, very high lactate or prothrombin time, then you have to stop the citrate. And then you can also increase the calcium replacement, right? If your ionized calciums are low, that's also something that you can do for hypocalcemia. All right, so hypercalcemia is, again, if the pre-filter ionized calcium is above 1.2 to 1.3, that's the definition of hypercalcemia. Again, it's not the total calcium. Because sometimes you will see a total calcium going up to like 11. That's not hypercalcemia. That's calcium citrate complexes giving you that high level. So look at the ionized calcium, okay? That's where the money is. And this is usually a quick fix. You just lower the calcium infusion, be it calcium chloride or calcium gluconate. All right, well, that's all I got. And I'll share these slides with you, and feel free to kind of share with the staff and then the recording as well. Do you have any questions in the chat? Yeah.
They're more likely to clog. This isn't due to any clog, correct? Like we would still have to, sometimes the patients are going down for clogging.
Yeah.
Like every 4 hours until like the sepsis gets better.
Mm-hmm.
Like is that population that you want to do this?
Yes, definitely. Absolutely. So what's going to happen is, you clog first and then you clog, right? So citrate will decrease, and that's the whole point of, it's going to increase the half-life of the filter, which basically means it's going to deal with the clogging as well. So if you start citrate from the get-go, and again, it depends how septic the patient is. If the patient is really septic, just like you said, that patient will clog and clot more often and quicker. But that's the whole point. If you give heparin to that patient and citrate is way superior. It's going to prolong your filter span. Absolutely. Absolutely. Yeah. And it's so interesting because when we started this, we got protocols from a lot of places like Emory, where my friend is, University of Alabama, IU. And we made our protocol very conservative. Whenever you start something new, you want to play it really safe, right? So that everybody gets used to it and gets comfortable. And pediatric nephrology, They have been using citrate before citrate was a thing. So they have tons and tons and tons of experience. So here at Riley Pediatric Nephrology, Dr. David Haynes is the chair. He's a very good friend of mine. And he says to me, I never look at lactate. I never look at, the LFTs. I just play, they have so much experience. And they actually use citrate on a 6-week baby and a 16-year-old kid. And 16-year-olds, some of them can be, adult size and all that. So they have so much experience with citrate, and just that's next door to us. Yeah. It's interesting because we are targeting a citrate level in the filter of 3 to 4 millimoles per liter. But in these bags, sometimes it could be 12 to 15 millimoles. So it's almost like 4 times the citrate, right? So that's something that we don't talk about as often, but it's really important to understand that, yeah, we are giving that citrate load as well. Exactly right. Yeah. Well, 60% is getting out of the filter, but 40% may still go back to the patient, right? And if the liver is good, it's going to get metabolized, no issues. But if the liver is questionable, and these patients we are giving blood products as well, then we have to be careful. Exactly right. Yeah. And we don't think about it, right? Like it's yeah. 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 And it's interesting because, I mean, a good CRRT delivery dose is a happy filter and a happy nurse, right? And that's the whole point. They say, if you have citrate, your span is increasing, you're spending less time in kind of, just putting everything together. And I'm telling you, 16 plus and minus 3 hours out of 24 hours is what the patient gets, right? So the patient may get like 13 hours. Whereas a nephrologist, he or she wrote the dose, right? They might be thinking, boy, our patient is getting 24 hours. And they dose the patient as if the patient is going to get it for 24 hours, right? So and I'm not sure. Sometimes, they know that the filter was down, and sometimes we don't, right? So that's something important. Any questions from the chat? You're so nice. Yeah. Sure. Absolutely. Yeah. And that's fair. Now, if you're seeing issues with acidosis, the potassiums, a patient is having arrhythmias, then I wouldn't wait, right? Just look at the patient. Yeah. But that's fair if you have a stable patient and it's a recurrent thing, then obviously, you should call. Because that way, the nephrologist knows that they may have to alter the dose or they may have to do something different, right? Yeah. Yeah. You dose for 24 hours. And that's a disconnect because that's your prescribed dose, but the delivered dose is different. And because there's no way of knowing if the filter is going to last 13 hours versus 16 plus 3, 20 hours, 19 to 20 hours. There's no way of knowing, right? So all your dose is based on a 24-hour period. And that's what you do. You do 25 to 30 cc's per kg per hour. So that is your 24-hour dose.
But I feel like a lot of patients in ICU are hemodynamically unstable,
Mhm.
and then when you're, it's adding 200, 300 cc
Yeah.
per hour, and I know theoretically, they're putting it in, but it just seems like it's causing, like, so much more instability in their blood pressure.
Mhm. Mhm.
And I know theoretically, I know, yeah, I know theoretically, like, you are putting that volume in, and you need to take it out.
Sure.
I feel like it never really worked that way. If their blood pressure is so low, you can't pull it all off.
Yeah. So what the answer to that is, that actually is not applicable just to citrate. That applies to anything, right? If the patient is really hemodynamically unstable, and sometimes you have to run those patients positive, and that's okay, right? Because that's all you got. They're already on 3 or 4 pressors. But that is not just a citrate issue. That applies to any drip, right? So, and citrate is not, sometimes you may be giving a lot of, drips at the same time. And within a 24-hour period, you may just find your patient 10 liters positive. Citrate is, 300 cc's an hour. So it's not negligible, but it's just like anything else, right? Absolutely. No, not per hour, per day. Oh, absolutely. Absolutely. Yeah. In fact, so from your admission weight, if you go up by 10%, that translates to increased mortality in the ICU. So, but some patients, so this is the, art of resuscitation. The first 24 to 48 hours, they will be positive. And then you start, the patients, either they get more hemodynamically stable, so you start pulling more, or LASIK starts working, et cetera, et cetera. Patients start peeing. So after 48 hours is the time to kind of de-escalate and de-resuscitate. But the first 24 to 48 hours in shock, I mean, that is more what's relevant to us. We don't do trauma or transfusion, trauma or transplant. But for our patients, the first 48 hours would be, the time to resuscitate. And I mean, it is what it is. Our patients get sick, and they might be positive. It's not uncommon for them to be positive in the first 48 hours. Good question.